I would like to introduce our last speaker, Professor Asu Ozdaglar from ECS. Asu?
Okay, thank you, Dimitris. So I will share my screen. And hopefully, let me make sure. Perfect. So thank you very much for the invitation. It's wonderful to be here with my close colleagues today. And also, I'm very glad I'm following on Dimitris's talk because he gave a lot of the background, related background to what I will be talking about. So as Dimitris mentioned, since March, many of the MIT community has redirected its efforts to try to come up with solutions and interventions that can help with the epidemic. And right now, Dimitris talked about vaccination, but it's not available right now. So my group's efforts in terms of thinking about interventions have focused on non-pharmacological interventions, such as lockdown policies, as well as testing that we've gotten very interested in. And today I'm going to talk to you about some of our very recent thinking and work on optimal adaptive testing, both for detection and nowcasting. And this is joint work with two brilliant ECS students, Alireza Falla and Sharat Patatel, a former postdoc who just started at Cornell, Francesca Parise, and Daron Asamoglu from MIT economics department. So evidence from many countries suggests that frequent and efficient testing is critical to understand the progression and containment of the epidemic. And many people have suggested high levels of infections in US are due to low and inefficient testing. But of course, in MIT, we are very blessed with the testing resources we have available, but many other places, most other places, testing is a very scarce resource. It's expensive, it's subject to supply constraints, as well as logistical issues in administering to a large pool. So despite this, there's relatively little work on thinking about how scarce testing resources can be optimally deployed. And in this paper, we actually make two contributions. We think about adaptive testing, which can actually, change testing levels as a function of the underlying state of the system. And this state by state, I mean the current infection levels in the community. So we actually will derive optimal PCR testing allocation for known state, and then use serological testing for nowcasting, essentially for estimating the underlying state of the system. And we'll see how to combine the two to come up with optimal allocation strategies. So as Dimitris mentioned, much of this work on interventions build on epidemiological models. He talked about SIR models, so I'll just be very quick here, I guess. So this is an epidemic model with 3 compartments or states. We think about susceptible, infected, and recovered agents, and the evolution of the dynamics of these states are given by the following equations. S dot is how susceptible agents change as time goes on. This decreases, there's a minus sign here, proportional to the new infections we have, which is given by the susceptible agents times the rate at which a susceptible agent gets infected. And this rate is given by the expression that I put here. This is basically the transmission probability. That's the probability that a susceptible agent gets infected, conditional on contact with an infected agent, times the number of contacts he has, times the probability that the contact was with an infected agent. So this, plugging this back in and S dot, that gives the evolution of susceptible agents. Infected agents basically change by the increase from infections minus the recovery given by the recovery rate, which is 1 over the length of disease, 1 over 14, times the number of infections, as well as the recovered changing as a, just like this part, that this decrease from here goes to this R dot. And R0 is a number people keep talking about. This is basically the average number of infections caused by an infected person in a population consisting of susceptible agents. And this is given by lambda times H, which is the number of infections per day caused by an infected agent, times how many days he's infected, 1 over gamma, and this is this beta over gamma. And as Dimitris mentioned, this is the classical SIR model, but if you look at the fit of this model to data, it's pretty poor because beta is time varying, and this is because of changes in the composition of the population in terms of vulnerability, behavioral responses over time, and other random factors. So our goal is to develop an optimal testing approach in a time-varying SIR model. We're going to assume this beta is time-varying. And then I already mentioned this, but I would like to highlight again 2 types of testing. Both of them will be critical in developing our approach, both in theory as well as in practice. We need PCR testing to detect who is infected and isolate. And we use serological testing for predicting the underlying state. And this is particularly important when beta is time varying to be able to estimate the state of the system. And I will derive an explicit characterization of the optimal control for testing, PCR testing, and then show how serological testing can be used to estimate the state. Before I dive into the results, I just like this sort of very simple illustration why PCR testing is not good for estimating the state. This is sort of these two panels show basically people getting infected during a virus outbreak. And the top panel is, each row is a person, and column is a one-time period. And here you can see, a person being detectable, potentially detectable, only for a short period of time. And this is what you can, detect using PCR testing. It can detect who is infected, which is a short event. And this is not very good as you look at the chart above for understanding the changes in the aggregate state. Here in the second chart, you see basically people who have been infected at some point in time. And this is how you can use serological testing, because it can detect antibodies and therefore can tell us who has been infected and give us information about history of infections. So I will get our simple SIR model and then complement it with the testing. So from 3 compartments, we go into 5 compartments. So this is right now I'm only doing PCR testing. So I use some time varying PCR testing rate, theta P of T, and proportional to that rate, I move individuals from infected to infected and detected. And now I have 2 buckets going, people recover from undetected infected and recover from detected infected. And the dynamics is basically just modified to take into account these movements across the compartments. I now have basically moved some of the infected people to infected detected, and then they recover to recover detected. And that's basically the only change from the SIR model that I talked about. So what's the control problem we think about? I will first assume we have perfect state information. And by that, I mean, I know the infected, recovered, and susceptible people in the community. So I would like to minimize the total number of tests we're using, which is a very scarce resource, subject to, I put a constraint that the number of infected remain below a certain level I bar, subject to the dynamics that I just talked about. So this is very similar to the optimization problem that Dimitris talked about, except I'm doing it for optimizing the testing resources. And this bound that I'm putting is basically to prevent uncontrolled exponential growth of the infections and keep overall infection levels low in the population. So this is an optimal control problem, coming up with the optimal policy is, takes some effort. So the way we actually proved the optimal, or figured out the optimal policy, is guess and prove. So this is basically using a numerical solver, we figured out the optimal policy, and it actually takes a very intuitive form. So this is how the susceptibles go down. And so the infected people, the fraction of infected agents is the blue one. And as you can see, when you apply the optimal control, which is the red dotted line, it basically first goes all the way very fast to I bar, stays at I bar, and then after a while starts decreasing. And the optimal control takes the form of 0 until it reaches this level, then applies some control to make it stay at the level of I, and then goes to 0 again. And if you look at the dynamics, if you want to actually make I dot equal to 0, I stay at the same level, the theta P that you need to be using is beta S of T minus gamma. So that is exactly the optimal control, which is when I is equal to I bar, use beta S minus gamma. So S will keep decreasing, meaning this quantity will become 0 at some point. And that's exactly this point here when the community reaches herd immunity. And with the minute, this is exactly when S of T is such that beta of S of T is equal to gamma. And then you let go of the control and the infections go down by themselves. And the proof for this is, I'm just put an outline that's sort of probably not to cover here, but basically the idea is you show that the optimal control must hit I bar. Otherwise you can reduce the control, constraint continues to be satisfied, objective decreases. And then you prove once you reach I bar, it's optimal to stay there until herd immunity. This is using Pontryaghin's principle for optimal control problems. And finally, there's another beautiful result from optimal control theory, which says that you actually make sure that you in the optimal control, you follow the most rapid approach path to the steady state to herd immunity, meaning that in the beginning, you use zero testing to get I to I bar and then start using your optimal control. So that's sort of the outline of the proof for this optimal control policy. So now let me assume state is known and apply my optimal control to, so far I talked about the epidemic model, but that's really a mean field model. It only tracks the averages. What we care about is the actual stochastic state of the system. So I apply the optimal control I derived from the epidemic model to the stochastic system, the underlying, large scale Markov chain with the corresponding rates, calibrated or obtained from the data. And you can see that actually the optimal control performs quite well. The infected person, here in this simulations, I bar is 1%, so it reaches I bar and then goes until it reaches herd immunity and starts going down on its own. So to understand, just compare the advantages we get from using optimal control, what I did here is compared it to the constant PCR testing and try to understand what kind of reductions this more sophisticated time-varying optimal control obtains. And for that, I use the same optimization problem. I just fix the PCR testing to a constant rate, or you can also get the same constraint from assuming, you want to guarantee IT is less than or equal to I bar for all times. That gives me this condition, and that gives me a condition on the constant theta p. And if I compare over 2 years what I would be using in terms of testing for time varying versus constant, for these levels of parameters, you see that with time varying, you get 26 tests, versus if you do constant, it's something like 162 tests per person over the time horizon we're considering. So there's a substantial amount of gains you can obtain by using this more sophisticated control. But this is all assuming that the state is known. And one might think that by using PCR testing, it's sufficient to estimate the state. But what we prove is the following. If beta t is time varying, which is what Dimitris just argued, system is not observable from its output. So by just looking at the PCR testing results, detected infected and detected recovered, you cannot estimate S of t, I of t, which are the susceptible agents or infected agents, and be able to use your control. So system is not observable. I have some arguments here that actually it's pretty cute, but I'm not going to go into the details of it. All we need to understand here is the system is not observable or identifiable. So this is why we're now introducing baseline serology. So this is my original model, remember, with PCR testing. So I put a little bit of this is the more important piece. So from the recovered, I apply serology testing to be able to understand who has had the disease. And this is the recovered detected agents in this compartment. And I also add here, even with very low efficiency levels, from the infected, some serology here with rate theta s. And that sort of changes my dynamics slightly. And the beauty is that for any theta s positive, the system now becomes observable. So if you do a little bit of serology, I can actually get the system state that will allow me to use the optimal control. And I just put here some argument why that's the case. Basically, you can look at this equation here, ID dot, and then you can invert I from ID if you have a positive theta s, and then from there you can get RD. So that's sort of, R. So that's how you actually get the state of the system. Of course, this is very, it's a terrible way of doing this. This is, right now we're looking at the noise-free system. The actual system has a lot of stochastic variations, a lot of noise. So in practice, and actually in the paper, what we do is we implement a state estimator or an extended Kalman filter to be able to estimate the state. And I want to emphasize here one more time that, the efficiency of the serological testing is not relevant for this analysis. For any, even for any level of efficiency, this result holds true. The system becomes identifiable with serological testing, although the new tests in serology seem to be very reliable. So with that, I just want to go back to my original example. Remember, I assumed the state was known. Now I assume state is not known. I use my state estimator to be able to estimate the state using serology and use the optimal control on that state. And basically what we see here is the impact of serology on our estimates. So remember, in the theory part, I assumed for any theta s positive, the system is identifiable. But I want to emphasize again that these epidemic models are just tracking the means. What we need to figure out in practice are the stochastic versions and the stochastic variability. And this shows basically that as you actually increase serology, the information or the signal you have becomes more stronger. And I tried basically using the same experiment both for different levels of serology, which shows that actually with reasonable levels of serology, the testing scheme we propose works. For example, for 30 days, if we do serology testing every 30 days to every individual, the mean here still tracks the intended behavior, except there's quite a bit of stochastic variability around the mean. And if you increase serology to every 7 days, for instance, that variability is significantly diminished. And we actually repeated our experiments to show more explicitly the benefits of serology. This is showing, for instance, as you increase the number of days in between serology, meaning you do serology less and less frequent, this is the overshoot that you will see in the number of, or the percentage of infected. That overshoot increases, not just in mean, but here I hope you can see the green, variances. The stochastic variability also in overshooting significantly increases. And this is just tracking, how much this infection levels overshoot. We were also interested, is this a singularity? Is it a single point, or overall it remains, above this I-bar level? So we look at also the integral of the infected surplus, and this is consistent with, the overshoot story, meaning that as you increase the days between serological testing, the overshoot becomes more also in aggregate. And then with this model you can actually do lots of different things, thinking about how do I combine, how do I use PCR and serological testing together. For instance, here we basically looked again at the trade-off between increase in the number of days between serology, meaning you use less and less serological testing, then you of course need to use more and more PCR. And similarly, we did the same thing for serology. And of course, as you do less and less frequent serology, serological testing goes down. So it would be actually of great interest to see, can I combine them? And actually it's very clear when you combine these two plots, there will be a sweet spot of how much serology you should be doing, and which one will give you the most optimal way of using your testing resources. So
I'm hoping we can conclude. We don't have a lot of time left.
I am concluding here, actually. I'm sorry, Dimitris. I just wanted to share sort of some of our recent work in this space that we're very excited about. Having access, more access. We are now using data at the Boston level, having access to more testing data, being able to use serology and see our results would be of great interest to us. So if there's anybody that would like to talk to us or collaborate with us on these dimensions, we would be very happy to do so. So with that, let me conclude, Dimitris.
Thank you.
And I will stop sharing so that I can see people maybe better.
Okay, so I actually have a question myself, Asu.
Please.
We'll give some time for our audience to also ask. I mean, I have looked into serology data, and unfortunately, it's not widely available. In other words, and when it is available, it's not of high quality. In other words, what is the impact of that, practically speaking?
I mean, right now it's very sporadic. I mean, the data is sporadic, where it's used is sporadic. But I think a lot of people think about it as, if I want to detect, its efficiency may not be great, and that's sort of the driving factor for use of serology. I think what this work is trying to make is a very different point. It's actually used as a surveillance of the entire, population level state, not individual state. And if you do that, the PCR testing can be much more efficiently deployed. So I think it's a new way of looking at it. And the other thing, Dimitris, so far, we're seeing infections increase, but I think serology is much more effective when you have some history built in. So I think we're at a point where we can use this idea and methodology in a very significant manner. And that's why exactly I'm now looking and working with some colleagues to get data. And there is some very interesting data coming from different states that we can use and build on these ideas.
One question is, what is the best serology test?
So So that's what I was trying to highlight. According to our theory, every little bit of serology would work in terms of getting it done. But I was trying to highlight that that's not reality. Reality is very noisy. So we started sort of looking at the minimum level of serology you need, and that depends very much on your system parameters, how you estimate the beta of T. But that's a very interesting and amazingly fruitful, future direction to be able to figure out what's the minimum level of serology needed to, be able to estimate the state.
Great. Thank you very much, Asu. We have concluded the first session exactly at 10:50 as promised. Thank you to all the speakers and the audience.
Wonderful. Thank you. Thanks, Bye.